بسم الله الرحمن الرحيم. معاكم الدكتور هشام الجيار أستاذ الغدد الصماء بكلية طب عين شمس. Mr. Chairman, dear colleagues, ladies and gentlemen, I have been assigned to review in my presentation the efficient glycemic control in type 2 diabetes. We will also review the composite program showing updates on sitagliptin, the DPP4 inhibitor. We have two objectives on treating type 2 diabetes. Number one, efficient glycemic control. Number two, preventing the development and delaying the progression of long-term complications. Efficient glycemic control includes lifestyle modification, treatment to a pre-specified target, which should be individualized according to the patient, age, duration of diabetes, life expectancy, the presence of comorbidities, and the capabilities of the patient. This target should be adopted early to get what we call the legacy effect on the cardiovascular complications, and it should be durable by continuous, timely monitoring of our patients and intensification accordingly. Efficient glycemic control also includes minimal hypoglycemia and minimal weight gain, if not weight loss, and cardiorenal protection. And what is very important in the efficient glycemic control is ensuring the adherence of our patients to the medication, and this could be done by educating the patient, by supporting the patients for the medications, and by the preference of the patient as regards the cost of the drug, as regards the cost of the drug, and as regards the ease of use of the drug and the tolerability of side effects. Intensive glycemic control could have a negative effect on the cardiovascular outcome if there is a cardiotoxicity of the drug, which was mentioned in sulfonylureas, for example, or in saxagliptin for heart failure. Again, if the drug induces hypoglycemia, this could have a negative effect on the cardiovascular outcome. Intensive glycemic control could have a neutral effect like most glucose-lowering drugs, and this is an FDA prerequisite before accepting the drug to be used for treatment of type 2 diabetes, and this is called non-inferiority or safety. Intensive cardiovascular outcome, intensive cardiovascular glycemic control could have a positive effect on cardiovascular outcome, and this we call it superiority or cardioprotective effect, which is one of them is the early intensive control, giving us the legacy effect manipulated by manipulating the oxidative stress and advanced glycation end product. Reducing insulin resistance again could have a beneficial effect on the cardiovascular outcome. Again, molecular extraglycemic effect could have this effect as shown in sodium glucose co-transporters and GLP-1 receptor agonist. A drug with nephroprotection could have a beneficial effect on the cardiovascular system because in renal patients, the main cause of death is in nephroprotection is the cardiovascular disease. This slide shows the legacy effect of early intensive glycemic control as shown in the UKPDS. Here we can see that during this active part of the study, the improvement on the cardiovascular outcome was non-significant. However, if we maintained this early glycemic control, we can see in the follow-up period that the effect on the cardiovascular outcome has become significant. This is called the good legacy effect. Late glycemic control results in permanent progression of complications due to non-enzymatic glycation of proteins, chronic inflammation, oxidative stress, and epigenetic epigenetic changes, and endothelial dysfunction. So we have a golden period in diabetes, and this is the first 3 to 5 years, which we call it the golden window for opportunity. And that's to say that we should early manage our patient to get benefit from this opportunity. Despite many therapeutic agents we have, we still face unmet glycemic targets. In 2008, we have this report showing that the majority of type 2 patients are not at A1C goal. We see here that in this report, 2/3 of our patients did not reach the A1C of 7%. In 2013, this huge study showed the same feature. Majority of type 2 patients are not at A1C goal. We can see here in the United States, the first column showed that 50% of patients do not reach the target. And in the other European countries with different color, showing a range from 25 to up to 48% of patients only reached the pre-specified target. Finally, in 2015, three big countries, Germany, United States, and the United Kingdom, showed again that the majority of patients of type 2 diabetes are not at A1C targets. For example, the United States showing 2/3 of the patients not reaching the target. What are the causes of unmet glycemic targets? We have two major causes. On the physician side, we have what we call therapeutic or clinical inertia, which is failing to intensify the treatment. And from the patient side, we have the non-adherence. The non-adherence of our patients could be due to difficulty in using the drug, like using injectables, or the non-availability or affordability of the drug in cases where the patients pay their medications out of their pockets, or the tolerability of the side effects is low, the patient preference, lack of education, and lack of support. So unmet glycemic targets could be due to therapeutic inertia or due to patient non. So what is clinical inertia? Clinical inertia means failure to advance therapy when required. We see on both of these slides that only a very small amount of patients advance their medications or their treatment plan when they do not reach the goal. Patients need 5 to 10 years to advance their medication to start to use insulin, for example. Clinical inertia means treatment to failure. We intensify our treatment later and not early enough and not intensive enough. So the next step is only when it is deemed needed to intensify the treatment. On the other hand, the proactive approach means early treatment to target. Patients with different indices of A1C show that most of the patients do not intensify the treatment. Most alarming was the finding that even among patients in the highest index of A1C category, that is more than 9%, therapy was not intensified in 44% of our patients. Interestingly, clinical inertia is present among primary care physicians as well as specialists. The primary care physician in blue and the specialist in red, showing that clinical inertia is nearly equal in both categories, except on starting insulin, where the inertia was present more in the primary care physicians, and which is evident that some are reluctant to start insulin. Clinical inertia increases the risk of cardiovascular events in patients with type 2 diabetes. It increases the risk of myocardial infarction by 67%, the stroke by 51%, the heart failure by 64%, and the composite endpoint of myocardial infarction, stroke, and heart failure by 62%. From this point of view, guidelines are moving towards earlier or even initial drug combination for treatment of type 2 diabetes, which results in better efficacy and durability. Early use of combination therapy is a well-known strategy in several therapeutic areas: cancer, HIV, hypertension, bronchial asthma, rheumatoid arthritis, and tuberculosis. Hypertension in type 2 patients usually need 2 to 4 drugs in combination to reach the pre-specified target. In the UKPDS study, the vast majority of patients with type 2 diabetes eventually require combination therapy. So after 5 years, 75% of patients needed more than one agent to control their hyperglycemia. So, what is the rationale for early combination therapy in type 2 diabetes? The first fact is that type 2 diabetes, the clinical diagnosis of type 2 diabetes is usually delayed 4 to 7 years. Secondly, the high baseline A1C usually needs the complementary effect of more than one agent. Number 3, combination therapy preserves the beta cell function. Number 4, the disease is multifactorial, so one agent cannot fit for all, one size cannot fit for all. Number 5, the clinical inertia we just mentioned, so early combination reduces the tendency to clinical inertia. Also, metformin failure. Metformin does not succeed in a big amount of patients. It's not always successful, as we are going to show. And the presence of combo preparations nowadays help us to early combine our medication. This slide showed secondary failure of metformin monotherapy if our baseline A1C is greater than 8. We see here with the red lines that the percent is higher, the percent of metformin failure is higher whenever we have a baseline A1C greater than 8. So it is wise to start combination therapy right from the start in this category of patients. Combination for glucose-lowering drugs could be initial or add-on. The initial combination can be dependent on the baseline A1C or independent as a strategy. The add-on, we call it sequential or stepped intensification of treatment. Early combination therapy appears to be superior than sequential combination therapy. That's to say that if we start our patients right from diagnosis by combination therapy, it appears to be more beneficial than sequential combination or sequential intensification. This is shown in the famous study of Defronzo, which was published 2015, showing that initial combination with metformin, pioglitazone, and exenatide is more effective than sequential add-on therapy with new onset diabetes. Results from the efficacy and durability of initial combination therapy for type 2 diabetes addict showed the following. That we can see here in green, the triple therapy was more superior than the conventional therapy as regards the failure. The triple therapy maintained its efficacy for a longer period than the stepped intensification. The same feature was seen as regards the DPP-4 inhibitors. Adding DPP-4 inhibitors to metformin early in the course of the disease appeared to be more beneficial. We have two studies on sitagliptin and another study called Verify for the vildagliptin. Both DPP-4 inhibitors showed clearly that if they are added to metformin early in the course of the disease, this may delay the need for exogenous insulin rather than stepped approach as usual. We all acknowledge the complementary actions of DPP-4 and metformin. So by this complementary action, we have better response with less side effects. An update on the DPP-4 sitagliptin was shown in the composite program. We have three arms of this program. Composite R, which is the comparison of sitagliptin with dapagliflozin in mild renal impairment. Composite I, which is comparison of sitagliptin versus placebo during the initiation and titration of the insulin glargine. And composite M, which is comparison of the uptitration of metformin plus sitagliptin versus metformin uptitration alone. The data of this program was published recently in 2018 and 2009. Let us start by composite M, which is the sitagliptin and uptitrated metformin versus uptitrated metformin alone. So that's to say that we early interfere with sitagliptin with uptitration of metformin. The results show that there was a greater reduction in A1C at week 20 with early sitagliptin versus placebo. So in composite M arm, patients with type 2 diabetes with inadequate glycemic control on metformin 1 gram daily, early initiation of sitagliptin simultaneously with metformin maximization up to 2 grams compared with metformin maximization alone provided greater reduction in A1C, no increase in body weight, and comparable safety and tolerability profile. So what about composite R, which is the addition of sitagliptin or dapagliflozin in patients with type 2 diabetes and mild renal impairment? In this arm, composite R, there was greater reduction in A1C at week 24 with sitagliptin as compared with dapagliflozin. In this arm, there was a numerically greater body weight reduction and blood pressure reduction with dapagliflozin as compared to sitagliptin. However, if we see here in the graph, the difference was statistically non-significant. In this arm, there was higher incidence of genital mycotic infection with dapagliflozin as compared to sitagliptin. We all acknowledge that DPP-4 are very neat drugs. They are greatly tolerable with very minimal, if any, side effects. That's the feature of the DPP-4 inhibitor, and this was shown with sitagliptin. So in this arm, patients with treatment with sitagliptin for 24 weeks resulted in greater reduction of A1C relative to treatment with dapagliflozin. Treatment with sitagliptin and treatment with dapagliflozin was generally well tolerated except for mycotic infection with dapagliflozin. And as we stress always, DPP-4 inhibitors are very neat drugs. They are greatly tolerable for our patients. So finally, in the composite I study,
efficacy and safety of continuing sitagliptin when we initiate insulin therapy in patients with type 2 diabetes, we studied the effect of this addition. The addition of sitagliptin to insulin resulted in a better A1C, less insulin dose, and more reduction of fasting plasma glucose. So we can say that sitagliptin has an insulin-sparing effect in patients with type 2 diabetes. Adding sitagliptin to insulin brought more patients to an A1C 7% than if we use insulin alone, and the documented symptomatic hypoglycemia was less when we added sitagliptin to the insulin. It did not increase the incidence of hypoglycemia in our patients, whether blood glucose less than 70 or blood glucose less than 56. So adding sitagliptin to insulin did not increase the incidence of hypoglycemia. So composite I states that adding sitagliptin to an insulin which is titrated in type 2 patient resulted in a greater reduction of A1C and fasting plasma glucose, and resulted in a greater percentage of patients reaching A1C less than 7%. They resulted in using a lower daily insulin dose, which is the insulin-sparing effect of sitagliptin, and with a similar overall tolerability and no added hypoglycemia when we added sitagliptin to the. So if we recommend initial combination therapy with metformin, would it be sulfonylurea or DPP-4 inhibitors? A very important question. This study, published in 2016, gives us the answer. Sulfonylureas compared to DPP-4 inhibitors in combination with metformin showed an increased risk of severe hypoglycemia, cardiovascular events, and all-cause mortality. Severe hypoglycemia was significantly higher in the sulfonylurea arm as compared to the DPP-4 arm. Cardiovascular disease, whether fatal or non-fatal, was higher in the arm using sulfonylureas as compared to the arm using DPP-4 with metformin. Again, all-cause mortality appeared to be higher, statistically significantly higher, in patient added sulfonylureas on metformin when compared to patients added DPP-4 on metformin. So we can clearly conclude that initial combination of metformin with sitagliptin is superior than adding sulfonylureas. Thanks for your attention.